Hello everyone. Okay, so let's do the general surgery portion revision. Uh, so let's discuss the shock and hemorrhage and septicemia and burns and blood transfusion. We will discuss each topic one by one. So the first topic is shock and hemorrhage. The definition of shock is that shock is the state of hypotension which is accompanied by hypoperfusion of the tissues caused either by decreased supply or inability of the tissues to use oxygen sufficiently to meet the metabolic requirements of the body. What is the definition of shock? Shock is the state of hypotension which is accompanied by hyperperfusion of the tissues caused either by decreased supply or inability of the tissues to use oxygen sufficiently to meet the metabolic requirement of the body. So in short, we can write that shock is a state of hypotension accompanied by hypoperfusion. Shock is a state of hypertension accompanied by hypoperfusion of tissues caused either by decreased supply or inability of the tissues caused by either decreased supply or inability of the tissues to use oxygen. Decreased supply or inability of tissue to use oxygen sufficiently to meet the metabolic requirement of the body. Okay, so this was shock and hemorrhage. Shock is a state of hypotension which is accompanied by hyperperfusion caused either by the decreased supply of the blood or inability of the tissue to use oxygen sufficiently to meet the metabolic requirement of the body. Okay, so this is the most easiest way to remember the definition perfectly. You should be having the key points. So in the definition of shock, we are having the key points of hypotension, hyperperfusion, inability of the inavailability of the blood or inability of the tissues to use this oxygen to meet the metabolic requirements. Okay, so these are the 5 terms. These are the key points, and this help out to remember the definition of shock. Now the types of shock, we are having CNS HVD. CNS HVD. So for C, cardiogenic shock. For N, we are having the neurogenic shock, cardiogenic shock, neurogenic shock, and septic shock. And for HVD, we are having hypovolumic shock, vasogenic shock, and distributive shock. Okay, cardiogenic shock, neurogenic shock, and septic shock. Then hypovolumic shock and vasogenic shock and distributive shock. Okay, so let's revise the blood transfusion. So the important things that we should learn in the blood transfusions are what are the different blood products and its uses, then various blood products, indications for transfusions of each product, and the complications of blood transfusions, the management, the prevention of complications, and defined massive blood transfusion. So the indications for blood transfusions are surgical indications, that is when accidental hemorrhage, ulcerative colitis, or hemorrhoids occur. Hemorrhage from the GIT tumors occur or bleeding peptic ulcers occur. And there are pre-operative indications in which if HB is less than 8 grams, then transfusion is done pre-operatively, and post-operatively if become anemic due to the infection or hemorrhage, reactionary secondary blood should be transfused. Transfusions are done in severe burns, that is must blood transfusions, and bleeding disorders, that is transfusion done in thrombocytopenia and hemophilia. So these are the important indications: surgical, pre-operatively, post-operatively, and in burns and in severe bleeding disorders. Now, what are the different blood products and its uses, and what are the specific indications for the transfusions of blood components? So the different blood products are cells and plasma. In cells, we are having packed red cells and platelets. So the packed red cells, these are indicated in severe anemia, small children, elderly patients, and in patients in whom introduction of the lung volume may cause volume overload. So only packed red cells are transfused if there are risk of hypervolemia. Platelets can store at 22 degrees C for 5 to 7 days and indicated in thrombocytopenia. If there are thrombocytopenia disorders, then platelets are transfused, and this can store at the temperature of 22 degrees C for 5 to 7 days. So this was one of the blood products, that is packed red cells. Now plasma, so remove after the centrifugation of whole blood. Blood is taken and it is centrifuged and the plasma is removed. Now we are having purified protein fraction and fresh frozen plasma. So in purified protein fraction plasma rich in protein which is suitable for replacement of proteins. For example, burn can store for several months under 4 degrees C. Okay, so plasma proteins are used in case of burns. If there is a deficiency of plasma protein, so the blood is centrifuged and the plasma proteins is removed, and this plasma protein is replaced when it can store at a temperature of 4 degrees C. Fresh frozen plasma, it is obtained from the fresh blood and is rapidly frozen and stored at -40 degrees C to -50 degrees C, and it is good source of clotting factors. Okay, if the body requires a clotting factors, then we will transfuse the fresh frozen plasma and it is stored at a temperature of -40 to -50 degrees C, and it is good source of clotting factor used for the patient with abnormal coagulation, severe renal failure, clotting factors deficiency, Christmas disease and hemophilia. Used for patients. Okay, so the fresh frozen plasma is used in case of coagulation disorders and severe renal failure, clotting factors deficiency and Christmas disease and hemophilia. These are all the bleeding disorders. So fresh frozen plasma is used for that. So we have studied that the blood content of the products which are packed red cells, in which there are these are cells and plasma. So in cells we are having packed red cells and platelets, and in plasma we are having fresh frozen plasma and purified protein fraction. So the purified plasma rich in protein, it is suitable for replacement of proteins. For example, after a burn can store for several months under 4 degrees C. And the fresh frozen plasma, plasma is obtained from the fresh blood which is rapidly frozen and stored at -40 to -50 degrees C, and it is good source of clotting factors. It is used for the patient with abnormal coagulation, severe renal failure, clotting factors deficiencies, Christmas disease and hemophilia. Okay, cryoprecipitate, fibrinogen and SAG mannitol blood. So cryoprecipitate is a rich source of factor 8 and it is stored at -40 degrees C and readily available for patients with hemophilia A, which is used in DIC. Fibrinogen is used in severe dilution of fibrinogen like DIC, and SAG mannitol blood. In this process, all plasma is removed and is replaced by 100 ml of crystallite solution containing sodium chloride, adenine, anhydrous glucose, mannitol, and contain no protein, which is good for anemia. So these are the different blood products. So one is cell and one is plasma. In the cell we are having packed red cells and platelets. In plasma we are having purified protein fractions and fresh frozen plasma and cryoprecipitates, fibrinogen, SAG mannitol. And cryoprecipitates are rich source of factor 8 and it is stored at -40 degrees C and it is readily available for the patients with hemophilia A and DIC. Fibrinogen is used in severe dilution of fibrinogen like DIC. In SAG mannitol blood, in this process all plasma is removed and is replaced by 100 ml of the crystallite solutions containing sodium chloride, which is 877 milligram. Okay, and it contains adenine, anhydrous glucose and mannitol. In this process all plasma is removed and is replaced by 100 ml of crystallite solutions. Okay, in SAG mannitol the plasma is removed and is replaced by 100 ml of crystallite solutions, and the crystallite solutions contain the sodium chloride and adenine and anhydrous glucose and mannitol. Okay, now how you will prevent the complications, or what are the safety measures during transfusion. We have studied that what are the indications for blood transfusion. Then we have studied that what are the different blood products. So these are cells and plasma. In cells we are having packed red cells and platelets. In plasma we are having purified protein fraction, then fresh frozen plasma, then cryoprecipitates, then fibrinogen and SAG mannitol. Fibrinogen, SAG mannitol and cryoprecipitate. Okay, now what are the prevention of complications? What are the safety measures during transfusion? So positive indication of the patient at bedside along with hospital administration number. Okay, you should identify the patient correctly. That is positive indication of the patient at bedside along with hospital administration number. Then the comparison of the name of the patient and blood group written on blood bag with strip provided by a blood bank. Okay, comparison of the name of the patient and blood group written on the blood bag with slip provided by a blood bank. Then the checking of ABO and RS group compatibility of each pack with patients and the examination of each bag for evidence of damage. If in doubt, then not use blood and return it. Then cross-matching is done, then check vitals before the transfusion and 40 drops per minute but can transfuse rapidly in severe blood loss. Blood transfusions notes should be mentioned, which must include vitals, blood bag numbers, date and time of transfusions, and reactions occur. Immediately stop transfusion if any reaction is noted, and observation should be at least for 15 minutes. Emergency medicine should be in hand at time of transfusion, and screening for HBV, HCV, and HIV is necessary. Screening for cytomegalovirus also recommended in special circumstances, and blood donor should be fit with no evidence of any active infection. So these are the preventions of complications and the safety measures during transfusions. First of all, positive indication of the patient at bedside along with the hospital administration number. Then the comparison of the Then the comparison of the name of the patient and blood group written on the blood bag with the slip provided by a blood bank. Then checking ABO and RH group compatibility of each pack with patients. Then examination of the each bag for evidence of damage. If any doubt, not use blood and return it. In cross-matching, then check vitals before transfusion, then 40 drops per minute but can transfuse rapidly in severe blood loss. The normal rate for blood transfusion is 40 drops per minute. Okay, you should remember this is MCQ point. The blood transfusions note should be mentioned, which must include vitals, blood bag numbers, date and time of transfusions, and reaction occurs. This should be mentioned. Then immediately stop transfusion if any reaction is noted. Observed should be at least for 15 minutes. Emergency medicine should be in hand at the time of transfusion, and screening for the HBV, HCV, and HIV is necessary. And screening for cytomegalovirus is also recommended in special circumstances. Blood donors should be fit with no evidence of any active infection. So these are the prevention of complication or safety measures during transfusions. Now, what are the complications of transfusions? So these are transfusion reactions and overloading, air embolism, and transmission of the disease, and potassium toxicity. So the transfusion reactions, in the transfusion reaction we are having acute immune hemolytic reactions. It occurs when donor and recipient does not match, and patient body release antibodies, which causes the hemolysis of RBCs, releasing harmful substances into bloodstream, and it is caused by IgG antibodies, leading to rigors, lumbar pain, dyspnea, hypotension, and hemoglobinuria. Stop transfusion. Urine output measure should be 100 ml per hour. Okay, when you are doing a transfusion, if these signs appear, that is rigors and lumbar pain and dyspnea, hypotension, and hemoglobinuria, and so you should stop the transfusion. This is a sign for the hemolytic reaction in which the breakdown of RBCs occur due to the mismatching of the blood, and this reaction is caused by IgG antibodies. So this is a transfusion reaction. In the first complication of the transfusion reaction is hemolytic reactions, acute immune hemolytic reactions. Then delayed hemolytic reaction. It occurs when body slowly attack the antigens other than ABO antigens. Okay, so first of all, the acute hemolytic reaction occur, then the delayed hemolytic reaction. So the delayed hemolytic reaction occur sometimes after the transfusion, and it occurs when body slowly attack antigens other than ABO antigens. Non-immune hemolytic transfusion reactions also occur. There may be allergic reactions, febrile reaction, fever occur, and graft versus host disease and transfusion-related acute lung injury may occur. So all of these are the transfusion reactions, complications, overloading of and the congestive cardiac failure, air embolism, transmission of the disease, and potassium toxicity, citrate toxicity, metabolic acidosis, hypothermia, hyperammonia, thrombophlebitis, and bleeding diathesis. All these are of the complications of the blood transfusions. These are acute transfusions, which are acute immune hemolytic reaction, delayed hemolytic reaction, non-immune hemolytic reaction, allergic reactions, febrile reactions, graft versus host disease, transfusion related acute lung injury, and overloading and CCF, air embolism, and transmission of the disease, and potassium toxicity. Then citrate toxicity, metabolic acidosis, hypothermia, hyperammonia, thrombophlebitis, and bleeding disorders. Okay, so all these are the non-immune hemolytic transfusions. Now the transfusion reactions: incompatibility, hemolytic transfusion treatment, febrile transfusion reaction, allergic reactions. These are the transfusion reactions. Okay, incompatibility, hemolytic transfusion reaction, febrile transfusion reaction, and allergic reaction. The infections are bacterial bacterial reaction, hepatitis, HIV, and malaria, and embolism, hyperkalemia, thrombophlebitis, metabolic acidosis, transfusion-related acute lung injury, and congestive cardiac failure. Okay, these are the transfusion reaction and these are the infections. So we have studied the complications of transfusion. These are transfusion reaction, that is acute immune hemolytic reaction, delayed hemolytic reaction, and non-immune hemolytic reaction, allergic reaction, febrile reaction, graft versus host disease, and transfusions, which are overloaded and CCF, and embolism, transmission of the disease, potassium toxicity, cytotoxicity, metabolic acidosis, hypothermia, hyperammonia, thrombophlebitis, peritonitis, transfusions, incompatibility, hemolytic transfusion reaction, febrile transfusion reaction, allergic reaction, and the infections are bacterial, hepatitis, HIV, and malaria, air embolism, hyperkalemia, thrombophlebitis, and metabolic acidosis, and transfusion-related acute lung injury, and congestive cardiac failure. Okay, now what is massive blood transfusion? So the replacement of patient's total blood volume in less than 24 hours or as acute administration of more than half of patient's estimated blood volume per hour is called massive blood transfusion. So what is massive blood transfusion? Whenever the patient blood is replaced and the replacement of the patient total blood volume is less than 24 hours, that is if the total amount of the blood that the patient requires is transfused is less than 24 hours or is acute administration of more than half of patient's estimated blood volume per hour is called massive blood transfusion. Replacement of the patient's total blood volume in less than 24 hours or as acute administration of more than half of patient's estimated blood volume per hour is called massive blood transfusions. Now, what are the risk factors? So the risk factors for the massive blood transfusion are dilutional thrombocytopenia, coagulation factor depletion, that is especially factor 5 and 8. All the coagulation factors are important, but the 5 and the 8 are the most important one. So the coagulation factor depletion, especially factor 5 and 8, autoaffinity decreases, hypocalcemia, hyperkalemia, metabolic acidosis due to citrate and ARDS, acute respiratory distress syndrome. So these are the risk factors, that is dilutional thrombocytopenia and coagulation factor depletion, especially factor 8 and 5, autoaffinity, hypocalcemia, hyperkalemia, metabolic acidosis, and ARDS. All these can occur due to massive transfusion. So what is massive transfusion? It is the replacement of patient's total blood volume in less than 24 hours or is acute administration of more than half of patient's estimated blood volume per hour is called massive blood transfusion. Now the management of the transfusion reactions. So the symptoms and signs of the transfusion reaction are fever, chills. These are the fever, chills, tachycardia, hyper or hypotension, collapse, rigors, flushing, urticaria, bone muscle and abdominal pain, shortness of breath, nausea, malaise, and respiratory distress. These are the management of transfusion reactions. Okay, so what are the symptoms? These are fever, chills, tachycardia, hyper or hypotension, collapse, rigors, flushing, urticaria, bone muscle and chest pain, shortness of breath, nausea, malaise, and respiratory distress. Now, the management options for the transfusion reaction. First of all, stop the transfusion in case of reaction. Then measure vitals, that is pulse, temperature, BP, and O2 saturation. Then check the identity of the recipient details on unit and compatibility form. Then check for fever, then urticaria, that is mild allergic reaction. Give give chlorophenamine 10 mg slowly intravenously and restart transfusion slowly. If the urticaria occur, then you have to give this of 10 mg, and for mild fever give paracetamol and restart transfusion and observe. Then for EBO incompatibility, take down unit and giving set return to the blood bank, then commence intravenous saline infusion, then monitor urine output or catheterize, maintain urine output at greater than 100 ml per hour, give furosemide if output fails. Treat only DIC with appropriate blood components and inform hospital department immediately. In case of severe allergic reaction, that is bronchospasm, angioedema, abdominal pain, and hypotension, return the blood. Give O2 and salbutamol and adrenaline for severe hypotension. Now the other hemolytic reactions are from give broad spectrum antibiotics and acute dyspnea, hypotension, transfusion related acute lung injury. Then give 100% saturation of O2 and treat as acute respiratory distress syndrome and fluid overload. Give O2 and furosemide. So this was the management of the massive blood transfusion or the transfusion reactions. First of all, stop the transfusion. Then measure vitals, that is pulse, temperature, BP, O2 saturation. Then check the identity of the recipient, details on unit and compatibility form. Then check for fever. Then urticaria. If it is mild energy reaction, then give chirofenibamine 10 mg slowly and restart the transfusion slowly. If it is mild fever, then give paracetamol and restart transfusion and observe. If it is ABO compatibility, then take down unit and giving set return to the blood bank. Commence intravenous saline infusion and monitor urine output. Catheterize, maintain urine output at greater than 100 ml per hour per give furosemide if output fails. Okay, if there is no urine output, then give furosemide and you should give the intravenous fluid. Treat only DIC with appropriate blood components and inform the hospital department. If it is a mild allergy reaction, then you will give the paracetamol and you will start a transfusion again. But if it is ABO compatibility, then you have to stop the transfusion, return it to the blood bank and give this anti-allergic agent to the patient, and intravenous saline infusion is done. And if DIC is there, then treat the DIC. Now in case of severe allergic reaction, that is bronchospasm, angioedema and abdominal pain or hypotension, return the blood, give chirofenibamine 10 mg and commerce O2, give salbutamol nebulizer and adrenaline for severe hypertension. Okay, this is the ABO compatibility. If there is severe ABO incompatibility, then you will give this 10 mg intravenously and give salbutamol for nebulization in case of shortness of breath and adrenaline in case of severe hypotension. Okay, now the other hemolytic reaction, give the broad spectrum antibiotics, and for acute dyspnea or hypotension transfusion related acute lung injury, give 100% O2 and treat as ARDS, and in case of fluid overload, give O2 and give furosemide. Okay, now coming towards the next topic, that is ATLS, acute trauma life support. Okay, now coming towards the ATLS. ATLS is advanced trauma life support. So what are the categories of different injuries and what is the management we will learn in this unit. So what is triage? Triage is process of determining the priority of patient's treatment based on severity of their condition. There are many schemes of triage and a common scheme are given below. Triage is a process of determining priority of patient's treatment based on severity of their condition, and there are many schemes of triage and a common scheme are given below. Determining priority of patient's treatment based on severity of their condition, and there are many schemes of triage and a common scheme are given below. Okay. So the triage sieve and the triage sort. The triage sieve is a quick survey is made to separate the dead and walking from injured, and triage sort is remaining casualties are now assessed and allocated to 3 or 4 groups. In first triage sieve is applied, in which the patients are separated according to the need, that is quick survey, and is made to separate the dead and walking from injured. The triage sort is the remaining casualties are now assessed and allocated to 3 or 4 groups. Category 1 labeled as red, critical and can't wait. Category 2 is labeled as yellow, urgent, serious injury but can't wait, can wait, short. And category 3 is labeled as green, which is less serious injuries and not endangered and can delay. Category 4 is labeled as black and it is expectant severe multi-system injury and survival is not likely. So the care should not be abandoned. Spare any remaining time and resources after immediate and delayed patients have been treated. So this was the distribution. We are having a triage. It is the process of determining the priority of patient's treatment based on severity of the condition. Then we are having the triage, which is a quick survey which is made to separate the dead and walking from injured. Then we are having the triage sort, in which the remaining casualties are now assessed and allocated to 3 or 4 groups. In category 1 we are having the critical patients which can't wait. In the category 2 we are having category 1 is red, Category 2 is yellow, in which there are urgent serious injuries, but they can wait shortly. In category 3, we are having green patients, which are less serious, which are having less serious injuries, and which are not in danger, which can delay. Category 4, in category 4 we are having black patients, and we are having expectant severe multi-system injury, and the survival is not likely. So there are 4 categories: the red, the yellow, the green, and the black. So the red required the instant treatment, the yellow required treatments but can wait shortly, and in the green there are less severe injuries, and they are not in danger, so the patient can be delay. In the category 4 we are having the black patients, in which there is severe multi-system injury and the survival is not likely, so the care should not be abandoned and spare any remaining time and resources after immediate and delayed patients have been treated. Okay, so ATLS. ATLS is advanced trauma life support. We are having primary survey, secondary survey, and tertiary survey. Okay, in ATLS is advanced trauma life support. ATLS, advanced trauma life support, and we are having 1 second. Okay. Okay, advanced trauma life support. So we are having the primary survey, the secondary survey, and the tertiary survey, and the tertiary care is the definitive care. Now the primary survey is A, B, C, D, E, and E. A, B, C, D, E. Okay, this is very important, as this is labeled in every question, that is whenever treatment is asked. So if it is emergency line, then the primary survey and the airway, cervical, spine immobilization, these are the methods that applied in every disease, so you should remember this. We are having the primary survey, in which we are having A, B, C, D, E. So A is airway and cervical spine immobilization, B is breathing and ventilation, airway and cervical spine, breathing and circulation. Then C is circulation and hemorrhage control, circulation and hemorrhage control. Then D is disability, that is neurological evaluation, and E is exposure plus environmental control, exposure plus environmental control. Okay, so this was all about the primary survey. First of all, whenever a patient is there, we will provide the primary survey. In primary survey we are having A, B, C, D, E. In airway and airway and cervical spine immobilization. In B we are having breathing and respiration. In C we will support the circulation and hemorrhage control. In D we will support the disability, that is neurological evaluation, and in E we will do the exposure plus environmental control. Okay, you should remember this on fingertips: airway, breathing, circulation, and for D is disability, and for E is exposure. Now after primary survey we will do the okay, these are the airway, these are the breathing, and these are the circulation, this is the disability, and this is exposure environmental support. So in airway and cervical spine immobilization, we will do suctioning of the nasopharyngeal airway, chin lift, and jaw thrust. Airway and cervical spine immobilization, the suctioning of the nasopharyngeal airway is done, chin lift is done, and jaw thrust is done. The advanced methods are for airway are endotracheal intubation and cricothyroidectomy and tracheostomy, and the prevention of cervical spine injury is done by immobilizing the patient, avoid hypertension of neck, hyperextension, and apply the cervical collars. So these are the methods: primary survey A, B, C, D, E, airway, cervical spine, breathing, circulation, hemorrhage, and disability and exposure. Airway, cervical spine immobilization, suctioning of the nasopharyngeal airway, chin lift, and jaw thrust. Advanced methods are endotracheal intubation, cricothyroidectomy, and tracheostomy. The prevention of cervical spine injuries: immobilize the patient, avoid hyperextension of the neck, and apply cervical collars. Okay, then we are having the breathing and ventilation. So expose the chest and assess respiration rate and type. Then give 2O2 inhalation, then check chest wall, lung and diaphragm by inspection, palpation, percussion and auscultation. Pulse oximetry is done. Look for life-threatening condition that impairs the ventilation. Tension pneumothorax, massive pneumothorax, open pneumothorax, pulmonary contusion and fracture. Fly chest, any assisted ventilation needed or not. Then for tension pneumothorax, wide bore cannula followed by chest intubation and fifth intercostal space. For massive hemothorax requires vigorous circulation followed by chest intubation. Then for flail chest managed by positive pressure ventilation. For cardiac tamponade needle pericardiocentesis may be life-saving in short-term. Thoracotomy and repair is required for definitive management. In circulation, look for the signs of shock, skin color, narrow pulse pressure, level of consciousness, hypotension, tachycardia, and diminished urine output, and control the hemorrhage. Apply direct pressure. Then pneumatic splanting devices. Assess need for surgical intervention. Then fluid replacement therapy. Double intravenous line should be maintained. Adults given 2-liter bolus fluid neglected, and children give 20 ml per kg bolus fluid. For disability dysfunction of the CNS, rapid neurological examination is done by AVPU method. A. Alertness, B. Voice response, B. Pen response, and U. Unresponsiveness. Raised intracranial pressure should be ruled out. Exposure and environmental support unless the patients completely induce trauma. Seizures prevent hypothermia by warm blanket and warm fluid.